Good evening. Welcome to our live webcast, Opioid Indications, Getting On, Staying On, Getting Off. Thank you for joining us. My name is Dr. Amir Jafari, and I'm Assistant Professor at University of Florida, Department of Anesthesiology, Division of Interventional Pain Medicine. I will be serving as the moderator for this webinar today. We are also joined by our other speakers, Dr. Sahid Wahisi, Dr. Matthew Maroney, and Dr. Priyanka Singla. Dr. Wahezi is a professor and a program director of Pain Medicine Fellowship at Montefiore Medical Center. Dr. Singla is an assistant professor at University of Virginia, Department of Anesthesiology, who is practicing interventional pain medicine. And Dr. Maroney is an assistant professor at University of Florida, Department of Anesthesiology, Division of Interventional Pain Medicine. Dr. Singla, I'm going to go ahead and hand it off to you. We're going to start our first presentation.
Thanks, Amir. All right. So,
I apologize. I guess Dr. Wahezi is going to be starting the first presentation.
That's okay. You know, any one of us can start. But we'll just format it this way if that's okay. I think it makes more sense to do the opioid metabolism first, and then this kind of like sets the table for everybody else. So I was tasked with giving the opioid metabolism part of this series. My hope is that the people who are listening to this lecture understand that everybody who's going to be speaking tonight wants to see that our opioid crisis becomes an eventual opioid concern, which eventually then becomes an opioid calm, right? That may take some time. That may take a generation or so. I think that the wheels have been put into motion for that to happen, and I believe that it's talks like this that's going to allow that to come to fruition, hopefully in my lifetime. All right. That being said, I think opioid metabolism is an extremely important element of understanding why opioids are a problem. And also, I want to create a foundation for everybody else's lectures in hopes of allowing you to understand why opioid metabolism is important, because it basically creates a framework for how we understand drug tests, how we understand how our bodies break these drugs down, what the byproducts are. And I think for most people, here's more immediate attention because there's going to be boards questions with regards to this stuff. Okay. So that being said, I'm going to go to next slide. Okay. So here's my outline. We're going to discuss phases of drug metabolism, and I only have 20 minutes to do this. And this can potentially be, a several-hour lecture, but I'm going to try to go through this. I may go through some slides faster than others, but I'm going to try to do it so that the most important aspects of the lecture I pause on, and other parts of the lecture, my hope is that everyone else pauses on. And if you have any questions, certainly feel free to contact any one of us, both during this presentation and afterwards as well. We're here to help. Phases of drug metabolism, the cytochrome system. We'll discuss that because there will be boards relevant questions on it, and I'll try to kind of tickle many slides with the cytochromes that will be testable. Opioid chemical structures, I'll be primarily focusing on the natural opioids, and I'll tell you which ones those are, because there's naturals and there are synthetic as well. Opioid metabolism, so there's several that we will discuss. I'm not going to go into detail about all of these, but there are going to be elements that will be questionable on your boards, meaning there will be parts where you will be required to understand and know. And the hope is that I can help you understand these things without necessarily memorizing. Okay. We'll give you a recap of metabolism, and why these cytochrome factors are important, not only when you consider opioids themselves, but also when you consider, the gestalt of the patient, which means who they are, what other kinds of medications they're taking, and if there's medications that interact with the stuff that actually metabolizes the opioids that we're going to be talking about today. Okay. So first, there are essentially two phases of drug metabolism. Okay. There's phase one, which simply put is the body's physiology creating a way to put an H and an OH molecule around a part of the chemical moiety that is most reactive to primarily a hydroxyl group. Okay. And what that does is it creates a more polar compound, and that polar compound will then be able to swim through the blood, right? Because because our blood is essentially polar, right? And so what happens is that when you put a polar compound, a relatively polar compound, into the blood, it eventually finds the kidneys. Once it finds the kidneys, then it can be excreted. Now, a lot of the medicines that we're going to be talking about today have renal excretion. Some of them have renal and hepatic excretion. We'll talk about that a little bit later on. But for the most part, by and large, renal excretion is phase one, and creating polarity. Our body's creating polarity of a particular molecule is important for excretion. Phase two of drug metabolism is when the body actually has energy requiring mechanisms to put large groups, large polar compounds, and attach them via covalent bonds to a particular moiety or two on a compound. Again, the same principle follows, making these agents more polarized. And when these agents are more polar, and when I say polar, my hope is that everyone understands that I'm also talking about hydrophilicity. And when they're created to be more hydrophilic, again, they swim around in the blood and then eventually find the kidneys, and then they're excreted in the kidneys. Okay. So the idea behind phase one and phase two is either by a simple or more complicated mechanism, or in other words, one that requires less energy versus more energy, means of creating, of imparting more hydrophilicity on a molecule so that it can eventually be excreted, okay, by the kidneys. Okay, here I'm basically saying the same kind of thing, all right? This R group basically is, a compound. Here you see an ether group. Here you see a hydroxyl group. Here you see a carbonyl group. And, these structures that have oxygen attached to them, if you remember back from organic chemistry, and yes, I will bring everyone back to organic chemistry for the next 15 or so minutes, oxygen, sulfur, these two groups, on the table of elements, they sit one right next to one another. They're juxtaposed. And if you remember the table of elements, most things on the right side and upper right side specifically are ones that are electrophilic. These are compounds that take electrons and pull it towards themselves. And the more electrons one pulls towards themselves, typically the more polar or the more hydrophilic a compound becomes. So here again, you see a hydroxyl group, an ether group, and a carbonyl group, which of these three, this tends to be the most polar, again, of these three. So when this chemical compound is imparted, the parent compound becomes more polar, becomes more amenable to being excreted, okay? Then you have, sulfation, acetylation, which we don't really talk about in this lecture, but I think it's important for people to know, and then glucuronidation. And glucuronidation is phase two, and a glucuronide compound is, well, almost exactly what it sounds like. Glucuronide, glucose, right? So it's a CH2O molecule, essentially in sugar form, right? Sugars are CH2O like compounds. And so A glucuronide group is essentially a sugar type of compound, glucose, ribose, fructose, whatever it is. And this becomes attached to the parent compound. And there's a lot of oxygens in fructose or in glucose, right? 5 and 6 oxygens that are being covalently bound to a parent molecule. This creates a significant amount of polarity. This creates then a compound that is much more lipophilic and that is much more easily excreted. Okay. So again, these are the ways that the body figures out to get a substance and put it in the blood and make it remain in the blood. All right. So understand that, because in the next couple of slides, that becomes a modestly important part of the discussion. Okay. Cytochromes. So we talked about this. They're large. They are phase 1 for the most part. They require a lot of energy. Okay. And we'll talk about two, primarily CYP3A4 and CYP2D6. And we'll talk about how these two compounds, which you'll be tested on, are involved in metabolism of opioids. They do more than just opioids, but just understand that will be our discussion today. All right. This is how they work here. I'm just telling you that there's a reductase, and it is essentially a big molecule that binds an agent. For the agent today that we'll be speaking about, primarily that substrate is going to be an opioid, and it takes that opioid, holds it into place, and when it holds it into place, attaches a water molecule and basically breaks the water molecule, but makes the parent compound more hydrophilic, right? And again, more easily excreted. I'm going to say these again and again and again, because my hope is that everyone understands the importance. So opiate chemical structures. You should take a look at these opiates. These are the non-synthetic opioids. Now, there's obviously codeine is modestly synthetic, right? I don't believe that this occurs in nature. Oxymorphone, oxycodone, all of these go down the stream of morphine metabolism, but all avenues eventually come back to this compound over here. Okay, I want to point special attention to this compound. For those of you who were listening and who I haven't put to sleep yet, I mentioned earlier about electrophilic agents. And I pointed to the ether group, I pointed to the hydroxyl group, I pointed to the carbonyl group earlier, right? And carbonyl groups are C double bond O's. What we didn't discuss a few slides ago was an ester group, which you see here, right? An oxygen bound to a carbonyl group. Now think about what this does. This oxygen and carbonyl group draw a lot of electrons in this area, right? Does the same thing here, draws a lot of electrons in this area. Now, if you could draw a line right here and split this part of the compound from this part of the compound, what you see is that what these two oxygens doing, and this actually behaves as a third oxygen because this is a double bond, right? So basically what's being done is that these oxygens are pulling electrons from this compound here, from this moiety here, and driving the electrical charge to this area, naturally creating polarity, naturally creating a hydrophilic structure. Now, this compound, heroin, is different fundamentally from the others, because if you look at this 3 and 6 position of this mother or parent compound, which you have a 3 and 6 in each one of these, oxymorphone, oxycodone, morphine, codeine, all of these have a 3 and a 6 position. The 3 and the 6 positions happen to be the positions that are most amenable to change. And actually, when pharmacists, chemists, change these molecules in a lab, they change them based upon these two areas, which have the space, both physical space and steric space. Steric just means like big and bulky. That's most amenable to change. Okay, so this is normally where most of the structures and changes happen. You'll see that that'll be a general theme throughout the next few slides. But the reason why heroin is so important, so if you take a look at morphine and heroin are almost the exact same compound, right? You have a hydroxyl group on the 3 and 6 positions on morphine, but you have an ester group on the 3 and 6 positions on heroin. This naturally means that when you assess for relative hydrophilicity, this is more hydrophilic than this. Why is that important? Why is that important in the abuse pathway? Well, in the abuse pathway, or maybe rather understanding abuse, you have to understand that this part of the parent compound is relatively lipophilic. What that means is that, this area here is able to get into the brain. It's able to get into the blood-brain barrier quickly. This area here allows the drug to get into the blood really quickly. So think about that for a moment. You have a compound that has a relatively hydrophobic or lipophilic moiety. You have an area that has a hydrophilic moiety. And so when this is put into blood, and how does this get into blood? Well, in most cases, when it's being abused, people put it in through IV. That means that the moment that it gets put in IV, the bloodstream sees it and just takes it, and it flows really with blood pressure, right? It takes it straight to areas where there's pockets of fat, and where are those pockets of fat and some of the densest areas of fat that blood will wash it to? Well, spinal cord in the brain. So people get high from heroin really quickly because you have this chemical structure that gets and incorporates itself into blood very, very quick, but then can also get into the brain really quick. Now, if you look at some of the other structures, take a look at codeine for a second, and take a look at oxycodone for a moment, right? Codeine has a hydroxyl group and an O-methyl group, right? The methyl group makes it a little bit of a sloppy hydrophilic agent, okay? Here you have a modestly sloppy hydrophilic agent here too, but the difference between codeine and oxycodone is that here's a hydroxyl group, but here you've got a carbonyl group. Again, this carbonyl group acts as a double oxygen, which pulls, right, these electrons here, which makes it, when you think about what I just talked about in terms of heroin, sorry about that, guys and gals.
Dr. Vahazy, you're muted.
Sorry about that. Thanks, Priya. Sorry about that. So I think the place where I was muted was when I was messing around with my arrow. But what I said was that this hydroxyl group on codeine, as compared to this carbonyl group on oxycodone, makes oxycodone relatively more hydrophilic, right? Relatively more as compared to codeine, and makes its abuse potential higher. Okay, so just think about that. And when you look at these compounds, think of these 3 and 6 positions as, as potential areas that you could look for to understand how abused they can be, right? So, all right. So the next thing that I want to comment on is, something that I mentioned earlier, and that is most roads point to morphine when it comes to metabolism. Codeine becomes morphine. Codeine becomes hydrocodone, and heroin, the way that we metabolize it, becomes morphine as well. I remember when I took my boards, I had a question about a patient who took a pill that was not recognized by a patient. And the patient said that, they felt pretty good with the pill, but when they had their drug test the next day in the pain physician's office, a metabolism from a metabolite from their that showed up in the urine was 6-monoacetyl morphine. 6-monoacetyl morphine. So this is a 3,6-diacetyl group, okay, attached to a parent opioid, or we'll call it a morphine compound, quote unquote. So what the body does is it rips the 3 group off, and you're left with a 6-monoacetyl. So when you see an acetyl group, usually what I want everyone to think is that it's probably heroin. That's part of the question stem. All right, that's important. For the next few slides, what I've actually done is I have indicated that not only do these medications themselves, not only do these agents impart an activity, but their metabolism imparts an activity as well. And so what I've done is, and I'll go to the next slide because I think I make it clear. No, I'll stay here actually. When you see pink, you'll know that these agents cause respiratory depression and hypotension. These are the more common side effects that one gets during an overdose. Okay, so that's one thing I want you to be mindful of. However, when one sees yellow, you think that the agent that the arrow is pointing to here and the agents that I will be encircling in the next couple of slides are indicative of the clinical reality, which is CNS toxicity and nausea and vomiting. So in this particular case, morphine, right, has primarily two initial metabolites, a M3G, which is a morphine 3 glucuronide, and now you know that that's a glucose agent that has been added, and there is a glucuronidase that does this, okay? And so you understand now that there's a sugar group, and the thing that does the metabolism has the sugar group in its name. So I think my hope is that helps you understand this metabolism. But morphine also has a M6G metabolite as well. That metabolite actually has more of this pink potency, right? So understand it from that point of view. Okay, and I'm saying the same thing here, right? The pink can be indicative of the active drug or the analgesic metabolite. Usually, the yellow circles are going to be the non-analgesic metabolites, okay? And the clinical effects are indicated here, right? Now, consider if the kidney doesn't work and you have a backup, in the body, then you'll get a buildup of both of these things. And this is one of the reasons why we have to be mindful of patients' GFR when we're providing some of these medications. And some are better than others, and it depends upon their metabolites when we're making that selection. And we'll see that in a little bit, and I'm sure that some of my colleagues will talk about it too. Okay, these are just arrows just pointing to things that I mentioned. Morphine, we talked about M3G and M6G. What I want everyone to understand is, what I said before, is that morphine and M6G have essentially a similar mu opioid effect, and that there is a anti-nociceptive potency to it, whereas the M3 effect can impart a CNS toxicity, right? Or CNS effect. Some of the agitation and some of the agitation effects and CNS effects come from this, okay? And that may be a question stem on your exam in about a year from now, okay? This is a UGT, and the GT stands for a glucuronide transferase. And I think I misspoke earlier, and I called it a glucuronidase. That's when the glucose actually gets cut off because it's an ACE. But this is a transferase. So this is an agent that takes a sugar and places a sugar on this compound, right? So when you see the glucuronide transferases, it means that there's an agent that now is being worked on by the transferase to put a glucose on it. And now my hope is everyone understands why that's being done, because it's a natural part of our metabolism to now rid that molecule from our body. Okay, codeine. Well, what do we see in codeine? We see that codeine becomes morphine. We mentioned that earlier. Morphine has both a potent effect, which is the M3G, which we talked about, and the M3G and the M6G. There's similar kind of things. So when you see codeine, kind of think along the pathways of morphine. So if you know the pathway of morphine, then you'll know the pathway of codeine. And codeine is a precursor and a prodrug, right? And for those who don't know what a prodrug is an agent that you take that has one form, but then our bodies actually turn it into the more active form, okay? It just so happens that the prodrug itself also has some mu anti-nociceptive effects, but so does the after effects in the metabolites. hydrocodone and hydromorphone. Understand here, that for the first time, we're seeing a CYP2D6 here. And the CYP2D6, you remember, because CYP2D6 is an agent. It is one of these cytochromes that does what? Well, usually adds a hydroxyl group across a molecule, right? And typically what that does is that displaces, in this particular case, CYP2D6, what it does is it displaces a methyl group from this oxygen here. So when you see the names on your exam, it's probably just easier to understand that this cytochrome in the discussions that we're having here primarily does an O-demethylation. O-demethylation, demethylates, takes the methyl group off. Okay, so if you know that, then when these questions pop up on your exam, and they can, you'll understand it. All right, so that's hydrocodone turning into hydromorphone, right? Hydromorphone also has a 3-glucuronide change. And consider, if anyone asks you, what's the enzyme? Well, you're smart now, and you're gonna understand it. It's a glucuronide transferase that does this, right? Okay. Oxycodone and morphone. Oxymorphone is a downstream metabolite of oxycodone, right? I changed it around a little bit because I couldn't find an oxymorphone molecule, so I put a hydroxyl here, which is where it should be. But again, look, CYP2D6, what does it do? It takes this methyl group off. It takes away a methyl group, so it's an it's an O-demethylation, right? It is involved in O-demethylation. Okay. And understand that these metabolites are things that you're going to see when you run drug tests too. So understanding these concepts, and they show up over and over again. If you know 2D6, you think about O-demethylation, you see these big, long words. My hope is that you'll understand what they mean. All right. We'll see momentarily that CYP3A4 takes a methyl group off of a nitrogen. Okay, we'll see that momentarily. Methadone, pretty clean in terms of its metabolites. You don't see any yellow stuff here. You just see pink. Okay, now here's another important element of methadone. Methadone is also excreted by, the colon and the biliary tree. So what does that mean? It means if this guy's not working, well, we can still get rid of it this way. Also means that it has pretty clean metabolites. Now, everyone here understands that it's not a perfect drug, right? It has a very narrow therapeutic action. There's a lot of weird things that can happen when you prescribe methadone. Those questions will be asked, but that goes beyond the elements of this particular presentation. So go to the next one, fentanyl. So look at this, inactive metabolites. That means that you don't see the pink stuff, you don't see the yellow stuff, except for the agent itself. Now, one thing I do want to point out, methadone is different from the other compounds. That parent morphine moiety that you saw earlier doesn't exist here. So this is a synthetic compound. Now, similar thing with fentanyl. Okay, it's a synthetic compound. Now, why does a compound that looks so different from morphine actually bind opioid receptors? Well, the idea is it's because of steric properties. It's not so much about how it looks like, when you draw it out and when you draw these ring structures, but it's about how these mu opioid receptors recognize the other element here, which almost behaves electrically like a ring structure. So when it falls into a mu opioid receptor, it kind of feels like, even though it doesn't look like a morphine moiety. Okay. But again, you take a look here. Again, clean metabolites. Tramadol. I'm not going to go much into here because I don't think there's going to be a lot in terms of tramadol metabolism on your exam. But I do want to comment on the fact that tramadol is a prodrug. Okay, here's tramadol right up here, and it's actually one of the conjugates that does the anti-nociceptive mu receptor agonism. Okay, so just understand that. We all know that tramadol also acts like a tricyclic antidepressant. It has that property. It has those properties as well. Okay, and that's because the electrical elements of this allow it to behave like a tricyclic. Okay, tricyclics, what do they look like? It's a 3-ring group, hence the term tricyclic. Okay, but it has that electrical configuration. Buprenorphine, very clean. I would not be surprised that when we start talking about the morphine calm to the morphine, well, I forgot what I termed it before, but quiet. I don't think I used that term, but concern to calm rather. I wouldn't be surprised if this is the agent that usurps all the other agents for pain management in the future. Okay, so just understand that this agent is important. Understand that this agent is a partial mu agonist and a kappa antagonist. Understand that its mu agonistic properties are such that it is a tighter bond. It creates a tighter bond to the mu opioid receptors as compared to all the other compounds that I've shown you earlier, which means that if you have buprenorphine, if someone has buprenorphine swimming around in the blood versus all the other stuff that I just showed you on the previous slides, and you've got a morphine receptor, what happens is that the buprenorphine will more selectively and more aggressively attack, attach, and remain on that mu opioid receptor as compared to the others. Okay? But it's a partial agonist. What does that mean? That means that though it attaches really, really tightly and attaches more powerfully than the other groups, the physiological effects downstream on that mu opioid receptor in the presynaptic cleft, in that synaptic cleft rather, is not as significant as if it was anything else that I showed you before, or many other things that I showed you before. That's what I mean by a partial mu agonist. Okay, binds more tightly than the others, but its physiological effect is not as strong as the others. And okay, metabolic pathways. We talked about this. We talked mostly about CYP 2D6. I didn't talk much about 3A4. Understand that exists. Understand that it takes a methyl group off of a nitrogen group. And with CYP 3A4, the name of the compound that is created when CYP 3A4 acts on it is usually a NOR compound, NOR. So NOR whatever. If you see NOR whatever, it means that a methyl group has been taken off of the nitrogen on the parent compound. Here, what I want people to understand is that on the CYP aspect of things, on these cytochromes, though they exist, and you have CYP3A4, you have CYP2D6, these are the two most important ones that you're going to be learning about. Okay, you have 2D6 here, you've got 3A4 here, but take a look at some of the medicines that bind these, and there's more than this, but take a look at some that bind. The importance of that is that there's some medications that patients will be given that deluge these receptors. And so because they're deluged, they may not be available for morphine to be metabolized, or codeine to be metabolized, or oxycodone or oxymorphone, which essentially means that now metabolism is going to be changed because these CYPs cannot work.
Here are some images of his.
Okay, I think that's all I got, guys and gals. I'm done with this now. Okay.
Thank you, Sayed. That was actually a very great lecture, and definitely very high yield material. Just as a reminder, there is a Q&A icon in the bottom of the screen that everyone can click on and submit their questions. All questions you submit are only seen by today's presenters and will be responded to in the order which they were received and will be addressed at the end of the presentation. Panelists will answer as many questions as time permits. All right. I'm going to go ahead and hand it off to Dr. Singla for the next presentation.
Thanks, Dr. Jafari. I'm going to be talking on how to initiate opioid therapy and how to, make sure that your patients stay on opioids safely, which is kind of contrary to, what the climate is right now with the opioid crisis. But one thing I want that all of you to take from this webinar is that opioids are not bad. What we require is responsible prescribing and responsible use of opioids. I don't have any disclosures. So the objectives of this talk is to talk about opioid initiation, maintenance of opioid therapy, challenges with opioid therapy, and the concept of opioid rotation. So this diagram demonstrates that, about 20% of adults in the United States have chronic pain, and a large chunk of those are on opioids, and most of them are on long-term opioids. This is the data from 2019, and I'm sure, with update of data, we'll see that more and more people are on opioids. The first part of the diagram kind of shows the gender differentiation. The orange bar is the males and the gray bar is the females. And we see that more females are on opioids as compared to males. When we break this down by age, the age group of kind of 30 to 65 is where, we see the most prevalence of opioid use. And it kind of decreases when, we see patients more than 65 years of age, which makes sense because the harmful effects of opioids are more pronounced as the patient population ages. So what the CDC says that, opioids are not the first line or routine therapy for chronic pain. And by chronic pain, they define it as pain for more than 3 months of duration. Now, this kind of recommendation excludes patients who are on palliative track, patients who have cancer pain, and sickle cell disease. So indications are that every attempt should be made to maximize the non-pharmacologic and non-opioid pharmacologic therapy. Now, an important thing to keep in mind is that you do not need to try every single non-pharmacological treatment, every single non-opioid therapy, every single injection that you have before you initiate opioids. Establish early on the goals for pain and function. The expected benefits from the opioid therapy should outweigh the risks, and that probably is one of the most important takeaways from this talk. When we're considering opioids, the best benefit should be more than the risk. There should be an early establishment of goals and opioid contract. There should be selection of immediate versus long-acting opioids, and I'll come to that later in the talk. The mantra is start low and go slow. Reassess periodically for pain and function. Evaluate risk of harm and discontinuation of therapy versus continuation of therapy. Recently, there have been some case reports where opioids were abruptly ended, and the patients near and dear end up suing up that physician that due to abrupt discontinuation of opioids, the patient kind of took their life. So that is something that we need to keep in mind, that the CDC provides framework for safe prescribing. It does in no way imply that somebody who's taken opioids for years and is taking them responsibly, that you should abruptly discontinue because of the opioid pandemic. So I'll touch briefly on the opioid contract. Before initiating opioid therapy, an opioid contract should be signed between the patient and the prescribing physician. And it is kind of an agreement that the patient will keep their part of the commitment and the physician will keep their part of the commitment. The patients, it should include the treatment goals for pain and function. And I would emphasize more on the function than on pain aspect of it, because pain numbers might not mean the same for two different individuals, but kind of the trend of pain numbers is important. But in my goal, the more important, in my opinion, the more important aspect to take into account is the function. Say, you have a patient who just wants to walk to the mailbox, who wants to play with their grandkids, and they are achieving that by 1 tablet of tramadol. I would say that's success, and that is something which is an improvement in function. Then it outlines patients' responsibility for safe medication use, that is, not taking more than prescribed, dangers of using it in combination with alcohol or other substance, such as benzodiazepine, unless closely monitored by the prescriber. So all the prescriptions should be limited to 1 prescriber. secure storage and safe disposal of opioids, and patients' responsibility to obtain prescribed opioids from only one clinician or practice, and preferably one pharmacy. On the physician's part, the commitment is to be available or to have a covering clinician available to care for unforeseen problems and to prescribe scheduled refills. And this should be renewed yearly. So when starting opioids, start with the smallest possible dose and with short-acting opioids. Initiate an opioid trial with less than 2 weeks of short-acting opioid. The benefits of using the short-acting opioid are that it's easier to stop if adverse effects occur. You will know within a few doses if adequate relief is obtained. Starting with an extended relief or long-acting product has greater risk of overdose, and there is no difference that has been shown in studies between short versus long-acting product on pain or function. If you are on a stable dose, you might as well transition to the long-acting form of the dose of the opioid once an appropriate daily dose has been determined. There should be a periodic review of the plan, and that essentially entails the 5 A's. That is analgesia, which is the pain control, activities of daily living, or ADL, which is more so the function. In my opinion, ADLs are more important than per se the control of pain. Adverse effects, aberrant drug-seeking behaviors, and affect. So in terms of aberrant drug-seeking behaviors, the PMP is a very important tool. So what the CDC says, CDC, has suggested that you should assess the risk and address the harms of opioid use. You should evaluate the risk factors for opioid-related harms and ways to mitigate the risk to the patient, which includes reviewing the PDMP data regularly, monitoring the urine drug testing, and that should be random. It should not be that, every 3 months the patient comes, then you are ordering a drug screen. It should not be predictable. Otherwise, you are not likely to succeed in opioid therapy. The other thing is that know your metabolites. Dr. Vahezi outlined a very important point that if somebody has 6-monoacetyl in their urine and you're prescribing morphine, then probably that person is using some illicit medications. And maybe you should have a conversation with the patient and see what your opioid contract says. Consideration of co-prescribing of benzodiazepines. There are certain state laws that mandate prescription of Narcan when you're co-prescribing benzos. Arrangement of treatment for opioid use disorder when you identify a patient with opioid use disorder. There are certain risk factors which put patients at high use of opioid misuse, and it's important to keep this in mind, which play an important role in the kind of involvement of substance abuse. These involve a strong family or personal history of prior substance abuse, young age of the patients, mood and personality disorders, history of criminal activity, childhood abuse, regular contact with others who misuse substances, risk-taking behavior, use of substances which lead to dependence, and psychosocial stressors. There are certain risk assessment tools that have been developed for chronic pain patients taking opioids. These include the SCREEN, an opioid assessment for patients with pain, the revised SOAP-R criteria, which is a trait measure of abuse risk. The current opioid misuse measure, the COM, assesses the state of abuse risk. Both these tools have been cross-validated and used extensively in clinical research. The PMQ questionnaire, along with other two, were found to be most valid in systematic review by Lawrence and colleagues. The urine drug testing. It is very important that you monitor your patients for the opioids that they are taking and the metabolites they are taking. It establishes the prescription compliance, identifies the use of other undisclosed substances, uncovers diversion. But I would be careful here because most of the urine drug tests have a cutoff at which they measure the metabolites. I have seen personally there are certain patients where the metabolites is less than the cutoff in the patient's blood, in the patient's urine stream. So in that case, the metabolite will come as negative. However, the patient is taking one as prescribed. So I would reach out to the lab and make sure that they run all the assays. And if there is below the limit cutoff of the metabolite, you are able to catch it. Should you do the urine drug screen? It should be done before initiating the opioid therapy. And stable patients should be screened randomly or at every visit. So this kind of, a table that kind of summarizes what Dr. Wahezi talked about in his prior talk. We all know that there are several concerns with opioid therapy. The short-term adverse effects are constipation, just seen in about 40% of the patients, nausea and vomiting in about 60% of the patients, sedation, about 20 to 60% of the patients, confusion, and respiratory depression. However, there are some long-term side effects as well, which include hypogonadism, osteoporosis, immunosuppression, and HPA axis suppression. In addition, we see tolerance or opioid-induced hyperalgesia and risks of addiction, abuse, and dependence. So how to differentiate between tolerance and hyperalgesia? Both of them kind of present in the similar way, that the patient will come and tell you, oh, I was taking 5 milligrams of oxycodone, say, for example, but it is not acting right now. It's not helping me right now. So how, as a clinician, can you differentiate between the two phenomena? In tolerance, the basic principle is that the receptors are down-regulated. The location of the patient's pain will be consistent with what it was when you initiated opioids, unless some new pathology developed. It occurs in all patients. There is waning efficacy of opioids over time. However, if you bump up the dose, you will see an improved analgesia. Hyperalgesia, on the other side, has upregulation of the receptors. You will see increasing distribution of painful areas. It is not symptomatic in all patients. You'll see similar waning efficacy of opioids over time. However, increasing the dose will not give you increased analgesic effect. So opioid rotation. There is a thought that switching from one opioid to another in an effort to improve clinical outcomes is something that can be done with different opioids. Say, for example, if a patient is taking oxycodone and you kind of have developed some tolerance, you might want to rotate them to Dilaudid or hydromorphone. Similarly, more potent opioids such as methadone. But I would weigh the risk of, switching the opioid versus the benefit that you might expect. When selecting a new drug, you start at a dose that minimizes the potential risks while maintaining the analgesic efficacy. And the indications for opioid rotation are lack of efficacy, development of tolerance, patients develop side effects, and sometimes there are insurance constraints as well, that insurance doesn't approve one form of opioid over the other. So patient characteristics to identify the opioid to switch to, take into account the patient's age, comorbidities, previous medication history, allergies, compliance, access to non-opioid drug in a combination product, adherence, reliance on oral medications, and insurance and financial considerations. Once you take that into account and you decide which medication to start on, then you move on kind of to the step 2, where you convert it into an equi-analgesic dose of current opioid using the various tools that are available online. I would say this is another of the favorite board topics, that they will ask you to convert one form of opioids to another. Now, when converting one form to another, there is an automatic safety factor that is taken into account. And based on the panel consensus, most of the switches, you should reduce the calculated dose to about 25%, some even say 50% of the analgesic dose. Then you assess for the patient characteristics and you further make adjustments. Like, say, if a patient is 85 years of age and you are trying to convert one opioid to another, I would be more on the conservative side and decrease the dose of the new opioid that you are going to start. You can always titrate it up. So there are 3 exceptions to this rule. One is methadone, which is a synthetic both I would say are synthetic opioids, right? Methadone and fentanyl. Methadone, the transdermal fentanyl, as well as the transmucosal fentanyl. So when you are switching to methadone, there is evidence of higher than anticipated potency in the clinical setting that suggests that the reduction in dose should be somewhere around 75 to 90%. Of course, you would use your clinical judgment with close monitoring. One of the examples that my mentors give very routinely is that, say you've initiated methadone and after one dose, the patient says, "Oh, my pain is all gone, I'm feeling great." Then you are in trouble, because it takes a while for more methadone to reach the analgesic equilibrium. So you should start low. In terms of transdermal fentanyl, this one-way conversion chart that converts equi-analgesic opioids to transdermal fentanyl has incorporated a safety factor already, and subsequent there is an automatic reductions, so you can probably use what is an equipotent dose. However, in terms of transmucosal fentanyl, which is rarely used, you should start with the lowest possible dose and forget about all the conversions. So these are kind of my references and questions we'll address at the end. Thank you, everybody.
Thank you so much. It is also very important to, there are general guidelines, but there are also state-specific guidelines, and you got to look into those and follow those as well. All right, we're going to go ahead and hand it off to Dr. Maroney.
Can you see that okay, Dr. Jafari?
Yes, sir.
Perfect. Okay, so again, Matthew Maroney here at University of Florida. We're going to briefly discuss opioid tapering. I have no disclosures. So basic objectives is considerations for when you should consider tapering, think about the risks, what basic strategies are there. You want to think about disposal, that can be a whole issue as well, and then what considerations there are for research topics. So a learning point for me for this was the fact that opioid therapy can fail. I think there's this kind of misnomer that opioids is can fix any type of pain condition, or at least temporarily, and can be a good treatment. And it's good for some pain. It's bad for others. So it's a tool. A lot of times I'll kind of discuss that with patients. It's a tool. It can be an appropriate tool in the right situation, though it doesn't work for every situation. So we're discussing specifically tapering. So best case scenario, which does happen, a patient may say, "Hey, I want to taper," and that's great, but that's the minority. That's the exception. Generally, the physician's going to be pursuing this topic for various reasons. Common reasons that may not make sense initially is that just the fact that it's not working. So it's obviously a dangerous therapy. If the patients, if they're coming back and their pain's just, not getting any better, well, the conversation shouldn't always go, okay, we're just going to go up. It should be, maybe this is the wrong move. Other things to consider is that they're just on too many medications. I've personally seen patients that opioid naive patients that were a little elderly, got a compression fracture, were started on small doses of Norco, like Norco 5. They just broke their back, and that is the reason that they had altered mental status and required hospitalization for this being completely altered, which is a kind of a life-threatening issue. So I mean, it's a real thing. Obviously, if the patient has you have them on morphine, a lot of us know these things already, but metabolites can be an issue. So if they're on morphine, all of a sudden they have kidney failure. Well, morphine is not the right thing anymore. You're going to have metabolites, so you at least have to convert to something else. Obviously, mental decompensation is an issue, and the more obvious reasons are, non-compliance, opioid trafficking, or an overdose event. In the other direction, I think it's important to kind of realize that just because someone's on a high dose doesn't mean that tapering is always the right move, but it should be considered. I think it's important to kind of realize that the strategies for opioids are kind of evolving. There's more of a focus on maybe lower doses than in the past. that's just the reality. Other considerations is, maybe indirectly related, but maybe a patient that you have on opioid therapy, everything's going relatively well, and then another provider, another physician, primary care or whatnot, started a benzodiazepine. Well, you may or may not decide that that's something you're comfortable with, and it may be indications for you to consider tapering off opioids if you're not comfortable with if it's an elderly patient, which generally it's a risky thing to have an elderly patient on opioids and benzodiazepine, so that might be an indirect reason to kind of initiate this. One thing that happens, it's happening a lot now, is that you may inherit a patient from another physician or your partner or somebody retiring, and kind of you might be in a situation where a patient's on a medication regimen that you're not comfortable with, and it may be an opportunity to discuss this. Though I think it's important to kind of point out that if you're just covering for somebody, that person's on vacation, you're going to see someone for one time, altering a multi-year treatment strategy that's probably just not very good timing. Because if you're going to initiate a change, and it's a pretty big deal to change someone's opioid therapy, and if you're not going to follow back up with them, you don't have a long-term plan, that's pretty risky. And then there's the other just random patient populations, patients doing well but then they're pregnant. Okay, well, that's a big deal. And there's a lot of data to suggest that if someone's on opioids, that just with cutting them off cold turkey, there's some risks in regards to that. So it's becoming more common to continue opioid therapy even when pregnant, maybe on buprenorphine or methadone, but that's a whole topic in itself. So motivating the patient is a big deal. A lot of this is kind of psychological things to consider, but they're incredibly important. You want patient buy-in. I mean, that's been pretty straightforward in the literature, that if a patient's buying into the tapering, the chance of you being successful is way higher. If you're forcing this on somebody, then the chance of them leaving or getting recreational drugs or some other issue is pretty high. So discussing the basics, I think, with patients are probably important. And the basics or the facts are that opioids are really good tools for short periods of time. Longer periods of time, the side effects increase and the efficacy decreases. So 12 weeks and below, opioids are kind of magical drugs that they can be very successful. But beyond that, the picture really changes. So motivating a patient to buy in, scaring them doesn't work as well as kind of thinking about the positives of withdrawal or of tapering down. So people are generally not that scared of dying. Patients that have been on medications for a long time, they think they have a handle on it, and in some cases they do. And they're not that worried that they're gonna overdose, even though it obviously does happen. But motivating them to kind of by discussing the side effects, decreasing their constipation, their nausea, increasing their energy level, increasing their mood, their sense of well-being. Those are real things that are expected. They're almost guaranteed, with tapering or completely tapering off. Obviously, it's pretty straightforward that sexual dysfunction is a pretty big issue. Hypogonadism, decreased testosterone in males, and that has huge impacts on someone's quality of life and energy. That can impact their bone quality, increase the risk of fractures. Obviously, hyperalgesia is kind of counterproductive in itself. But selling it, not that it's easy, but that you're pretty much guaranteed to have the opposite effects. You're going to have better mood, you're going to have better energy, better physical function, you're going to have decreased anxiety. Those are all things that you can honestly say that are very likely. And then from a mortality standpoint, these are real numbers. Like your risk of death doubles if your morphine equivalents are over 100. Like these are not small numbers. A lot of times people are treated with aspirin or this or that to decrease the chance of a stroke by single digit percentage points. These are 100% improvement or worsening chances of death. So there obviously are risks associated with tapering that you should wrap your head around. Obviously, if you abruptly discontinue them, then there's real life-threatening issues, and really we're not So therefore, it's not really recommended to abruptly discontinue unless you are, concerned for their life or they're doing something very inappropriate. The reason that you can have life-threatening issues is that, if someone stops opioids, their tolerance will plummet, and then they get back on a medication they think they're familiar with, and they can die taking the same amounts. Obviously, people are if they're desperate, which they frequently will be, they're going to go get illicit drugs, some other forms of drugs. So again, overdose is incredibly dangerous in this situation. Obviously, a big negative would be poor pain control. That's the whole reason they were on opioids. Other things to consider that are real: risk of suicide. People do commit suicide tapering from opioids. Obviously, people commit suicide for a lot of reasons. The chance of that is more significant in the first few months. It decreases after the first few months. But obviously, if your mood drops, some people go that direction. So really, I think being straightforward with patients, telling them what to expect, so they're not surprised by it. People can generally wrap their head around something that they kind of expect. So talking about symptoms, side effects, kind of the negatives, and trying to focus on, the distant future where those will pass, is important. So what are the symptoms? Obviously, they could be pretty much the opposite of the medication. So anxiety, headaches, nausea, muscle aches, poor sleeping. I mean, the insomnia is apparently one of the worst parts of it because they're just sitting in bed hating their lives. So when do you expect that? Well, if you're doing kind of short acting medications, it's going to be in the first maybe 24 hours. If you're doing extended release medications, it can be in a few days. So obviously methadone lasts longer. And there are some things that you can treat. Obviously you can't get rid of all these things, but clonidine is a really common one for for some of the shakes and jitteriness and all those things. You can use antiemetics, anti-diarrhea agents. Obviously the acetaminophen and NSAIDs for pain, and you can use trazodone in some cases. I'm not saying use these every time, but they're options for insomnia. And if the patient's doing really poor, maybe you're just tapering too quickly, and the timing of that's a whole consideration. You may or may not have heard about ultra rapid detoxification, which is literally like someone goes under general anesthesia and they give them, an opioid antagonist, and there was thought that maybe they'll get through the worst of it while they're unconscious. But my understanding is the risk of death there is pretty real, and it's obviously incredibly expensive, and apparently not that successful. So again, getting the patient to buy in, having some shared decision making is incredibly important. Explaining what to expect, expecting, poor pain control. So what are you going to do about that? Having some other strategy, telling the patient you're not going to abandon them so they don't abandon themselves or find other sources of information. And I would say frequent follow-ups are important. Depending on the patient, you might, the recommendation can vary from seeing them every week to maybe once a month, but more is likely better. So the question is, fast, slow, and that's going to be an individualized, decision. I think some people kind of mistake this process and assume it's going to be days or weeks. And if it's someone that's been on medication for months or years, it could take months or over a year to taper them. So basic recommendations, there's a CDC pocket guide for this, and I was kind of surprised when I first learned about this, but I mean, kind of a general recommendation, maybe 10% decrease per month. So if you're doing that, you're hitting a year pretty easily. Obviously, if someone's not been on medications that long, you can go faster. So maybe a 10% decrease a week. I mean, you're taking all these things into consideration. There's a recommendation from the VA. They go even slower. In some cases, they might go 5% over 4 weeks. But you get the idea. It's a percentage over weeks, months, and then you're frequently reassessing and readjusting, and you may even slow it down or pause it. This is just a little pocket guide from I believe the VA, but if you look on the left, I mean, you can see that the reduction may be as slow as 2% over 4 to 8 weeks. So I mean, this could be a multi-year process. Obviously, like the one all the way on the right, so you're completely tapered off in 11 days. But just to kind of give you the range. So most commonly, again, 5 to 20% every 4 weeks, I think on roughly 10% every 4 weeks. got to be individualized. And the reason is that once you kind of get over 10%, you can look at the chance of overdose and mental health crisis. So like, you know, anxiety issues and whatnot. So if you're about 10%, the chances of overdose, I mean, that's per 100 person years is, you know, on the lower aspect, that's 6. But once you kind of, you know, go up to 10% or more, it can double. And the mental health crisis is obviously pretty significant. So this is over decreasing it. If you decrease it by more than 20%, you know, the chance of them having a severe mental health crisis skyrockets. If it's over 50%, it's pretty significantly high. Completely separate, but I think this is one of the more interesting things, is that you know, patients that have hypogonadism, especially in men, there's a consideration that that's due to the mu agonist, and that testosterone replacement has been shown to actually improve pain and function, specifically emotional functioning, which, you know, is that's a lot of the misery in regards to withdrawal has to do with obviously emotions. It doesn't. So I could see that going somewhere in the, you know, maybe near future. It's not going to fix sleep, but it's, you know, a safe tool, obviously. Special populations, obviously there's opioid use disorder where well, the DSM-5 criteria of that is when you see problematic patterns with distress, and so this is obviously like a diagnosis, opioid use disorder. The kind of creepy thing about this is that it's incredibly easy to be diagnosed with this, and then you're going to see that on people's charts, and obviously that's it stigmatizes the patient. And if you just have 2 symptoms, so you could be trying to taper, you have withdrawal symptoms, and you have cravings. Well, by this criteria, you could have mild opioid use disorder. So I guess the reason I'm pointing this out is that, you know, there's a big difference between having 2 of these and, you know, all of them. 2 of them, you could be trying to doing everything appropriately and being labeled appropriately, but you know, the stigma is pretty real for obvious reasons. So just be kind of careful about, like, you know, how was this diagnosed and what's the implications of that. Things to consider, again, beyond naloxone prescription, you can do an addiction medicine consultation. Buprenorphine obviously is a really common medication for the situation. There's a new update from December 2022, so less than a year ago, where the ability for physicians in general to get this medication it's improved quite a bit. Before December, you needed what's called a data waiver, where you had to, you know, get kind of I don't know, go through classes and whatnot, and to be able to prescribe buprenorphine for opioid misuse, and now that's gone. So the reason this is important is that I've already had consults from, you know, hospitalists or whatnot that, you know, want you know, a patient to continue buprenorphine or whatnot, and they you know, there's an assumption that you need to be a pain specialist to use it. Obviously you want to be comfortable with the medication, but you don't need to be a specialist, and now you don't even need a waiver. The benefits of buprenorphine is that it's not a pure opioid agonist, it's a partial, so there's a decreased concern for, you know, respiratory failure, death, though you can still die from it. It's not that safe. Let's see. Other considerations is that there's been a little bit of studies in regards to this. And, you know, say you inherit someone that is in incredibly high doses of opioids, you could consider sending them to an opioid specialty clinic. There's been studies with this, and the results are actually pretty good, where, you know, these patients are probably the most difficult patients to, you know, to taper down. They have very high morphine equivalents, and in these studies, or this one study specifically, 45% were tapered down to, you know, what's the recommended doses to, you know, 90 or below, and then 18% were transitioned to buprenorphine. So of high-risk patients, 63% had a good outcome or improved outcome. So, you know, it does show that you can have success, you know, with these strategies, or sending someone to a clinic that's more comfortable with this information. If you were going to consider using buprenorphine, I think from a basic standpoint, it's important to kind of realize that the timing's important. So if you're converting a patient from a full opioid agonist, you don't want to just start them on buprenorphine immediately, because you'll precipitate withdrawal, because it's a partial agonist, so it'll compete and kind of bump the full agonist off the mu opioid receptor. So the recommendation is that you actually let them kind of fall into mild to moderate withdrawal and then start it. And from a patient standpoint, obviously, if you give them buprenorphine and they just start withdrawing, they're probably not going to buy into that medication. So you might lose your chance to start a medication that's pretty safe. This is just a kind of thought tree, but the idea is that pretty much every medication that's on opioids, this should always be a consideration. Do they need to be on opioids? Can what's the lowest dose you can place them on? And if you just kind of go through it, it's just, you're periodically always reassessing this. It's always a question. You're not kind of like set it and forget it, which can happen, I think, frequently. Just briefly, you also want to discuss, if you're giving opioids, like how to dispose of them. There are certain pharmacies that you can dispose of them, but you don't, preferably if a patient has a huge amount of them, especially in the case where maybe a family member dies and they're a cancer patient, you don't want to just stick a few hundred pills in the trash, or which can be obviously stolen, or I think it can get the sewage, and it can get the surrounding water, and that's not particularly very good either. So there's the recommendation is put it in like something that someone's not going to find and just be able to use. So throw it in kitty litter or dirt or coffee grounds. Flushing is an option, though. My understanding is that there's been situations where this sewer water has gotten and actually impacted wildlife, which is suboptimal. Room for research, obviously. What's the perfect speed and how to taper? I don't think that's ever going to be perfectly understood, but more information, more kind of structured studies would be useful. Let's see, and what other interventions can assist opioid tapering? Again, I think testosterone has a lot of promise, but there's we're hitting a kind of a milestone in opioid therapy, and hopefully it's going to continue transitioning to minimizing or being conservative with it, because opioids can be pretty dirty. Those are my references. Thank you, guys.
Thank you. So there are two questions in the Q&A box, and they're both answered by Dr. Vahizi. They're both available to read. The first question is interesting. It's regarding the buprenorphine, which Dr. Moroney was discussing, and its replacement for other opioids. Buprenorphine is has a ceiling effect, so that's why it has a reduced respiratory depression side effect. So as the patient receives more and more, there's a ceiling effect of how much it can cause respiratory depression. So that's why it's safer in that sense. And it is a mu partial agonist, and it does have a higher affinity for these mu receptors. And that's the reason Dr. Moroney was discussing. If you start someone on buprenorphine while they're on other opioids, it can cause withdrawal symptoms. And the second question is regarding using opioids as in the intrathecal route. We also have a chat box. If anyone, I don't see any questions in there. Please, if you have anyone other questions, please go ahead and add it. Otherwise, we will conclude this session.
Thank you, everybody, for attending.
All right. Thank you, Dr. Moroney, Dr. Vahazi, and Dr. Singla. I appreciate it. Those great lectures. On behalf of ASRA Pain Medicine and the APPD, I would like to thank you for your participation in today's event. The next ASRA Pain Medicine APPD Hot Topic webinar will be taking place on November 7th, and will focus on radiofrequency interventions for the facet joints, background, improving outcomes, and guidelines. We hope to see you then. Thank you and have a pleasant evening.